Well, welcome everybody. Thank you so much for joining us. And I have worked in the field of Alzheimer's and related dementias specifically for now over 30 years. Just a quick little bit about my background. I started in adult daycare specific to mid to late stage Alzheimer's and related dementia. I've worked in home care. I was in the very first Alzheimer's specific assisted living in the country as the original activity director. And then I opened and ran an Alzheimer's specific assisted living in New Jersey. I worked for the Alzheimer's Association for 14 years and then worked for a small independent group that did consulting with professionals and families for 5 years. And now I've been on my own for the last few years. But I always consider my most valuable experience was as a caregiver for my grandmother who had vascular dementia. So that's a little bit about me. And now I'm going to jump right into it. And I actually, I love the title of this, but I'm going to already contradict it right from the bat, right? Alzheimer's, its typical path. The first rule of Alzheimer's disease is that there's no typical path. We're going to talk through the different stages of the disease and what you might see, but I'm going to remind us throughout that every individual with this disease is affected uniquely because it affects people as unique as they are. And you may want to ask as we go through the different stages of the disease, well, how long does somebody stay in a particular stage? And I'm actually not going to put numbers to it because you can't. You never know. It really is based upon so many factors for the individual as to how long he or she may be in one stage and then move into another. But it can go anywhere from 3 to 20 years or longer. But not all symptomatic. So we'll talk through that. I'm first going to start though with a short video clip. And every year the Alzheimer's Association puts together a comprehensive research packet called the Facts and Figures, and they accompany it with a video clip. So I'm just going to show the 2022 Facts and Figures to kind of see where we are currently with Alzheimer's disease and related dementias. I'm going to stop there for a moment. Some people know these statistics, other people it's a complete surprise because we don't often view Alzheimer's disease as a terminal illness, as a cause of death, because it can go over such a long period of time. But it is currently, well, actually until COVID, was the 6th leading cause of death among adults in this country. And I'll ask, does anyone have any questions or comments to that before we move on to the next?
I don't see anything as yet.
Perfect. All right, so let's jump in. First, I want to talk about the term dementia because dementia is often used interchangeably. It's Alzheimer's or it's dementia. The reality is dementia is not the disease itself. Dementia is merely the category of symptoms. So when we hear the term dementia, we want to think of it almost like we think of cancer, not comparing the two. But cancer is not the disease, it's the category of symptoms. The first question we tend to ask when we hear cancer is what kind, what's causing the symptoms? And when we hear that term dementia, we actually want to ask the same question, what is causing those symptoms? So that's an important distinction. In terms of dementia, probably the word it most closely replaced was senility. If you remember that term, We believe that you get old, you get senile, it's normal, it's everyone's going to do it. The reality is it's not a normal process of aging, and everybody's not necessarily going to get it. Dementia doesn't encompass all forgetfulness. There are criteria to be diagnosed with a dementia. And the first one is that memory issues have to be severe enough that they interfere with the person's ability to carry out daily activities. So what does that mean? A good example would be if anyone's ever lost your keys. That is very frustrating. I'm going to bet that we've all done that at one time or another. We typically can retrace our steps and find where we left the keys and move on with our day. However, if a person has a disease like Alzheimer's disease, one of the things the disease does is takes away the person's ability to sequence events. So if you can't remember where you started to retrace your steps, then you're never going to get there. So a person with Alzheimer's, when something like that happens, they can't move forward with the next thing they were going to do. So it interferes with your ability to carry out your daily activities. The other criteria is that it has to affect at least two of what they call the four core mental abilities. So the first is recent memory. And with Alzheimer's, that's probably the first thing we think of when we even hear that term. Recent memory is short-term memory. So for most of us, short-term memory is a choice. If something's important to you, you do whatever works for you, and we're all unique, right? Maybe it's writing it down, repeating it 3 times, having someone remind you. But we do whatever works for us to take it from short-term and commit it to our long-term memory so that we can recall it later. When a person has Alzheimer's disease, this ability is taken away. So a person can no longer take any new information, no matter how important, and commit it to long-term memory. The second is language. And by language, we mean receptive language. So basically, how a person understands written or spoken word. So you may have a person at a restaurant, and the person looks at the menu and they read everything on it perfectly clearly. And then you say, "What would you like?" And the person goes, "I don't know. What do you have?" Because reading is a long-term retained skill. However, the word and what it cognitively represents is now starting to fade away. So while the person may be able to read it fine, it's not connecting with what that actually means. And I see there's a question. I don't know if we want to read that or.
Yes. The question is, do I get this disease more likely earlier after I got COVID-19?
That's a very good question. And frankly, nobody knows this yet. In all honesty, they're saying that there is a possible link between COVID-19 and Alzheimer's disease because of its effects on the body. But the reality is, we only know as far out as the first person diagnosed. So there's not a lot of long-term data on it. There is that brain fog, and we're seeing cognitive issues with individuals who've had COVID-19. But right now, I don't think anyone can say confidently that that means that a person will get Alzheimer's disease, or will this brain fog, if you will, clear in time, kind of like we see with anesthesia with older people. So I know that's not, the exact answer, but I honestly, there isn't one yet because we just don't know enough. We're not far enough away from it to really know, is there a 100% connection between Alzheimer's disease and COVID-19? But that's a very good question. And then the third core function is executive function, which is safety awareness, a person's ability to plan and follow through on a task. And finally, visuospatial function. We know that vision changes with age. We also know that vision changes with Alzheimer's disease. As Alzheimer's progresses, really starting in the moderate stages, people begin to lose their peripheral vision. So they develop what we call a tunnel vision. And you can tell when this is happening by watching somebody walk, sit, or eat. If someone's walking and not really cognizant of things on the side or even on the ground on the side, people can trip, they can hit door frames, all kinds of things. Sitting, if someone's missing the chair or sitting on the edge of the chair, that's that peripheral visuospatial, or not visuospatial, but those are vision changes that we can see with Alzheimer's disease. Now, visuospatial function actually specifically speaks to how your brain understands and translates lines, maps, and symbols. See, I made up a word. So if you think about, You go into any public building, there's always an evacuation route map. It's just a basic drawing, right, of the floor plan with a red line that says you're here and then shows you with the red line how to get to the nearest exit. When a person is having difficulty with their visuospatial function, they can look right at that map and have no idea where they are within the context of the building or how to get out. You can also see this in driving, and I'll give an example of how at least 2 or more of these areas need to be affected to be considered a dementia. So say somebody is driving their car, they come to a stop sign. So maybe they're having some issues with receptive language, understanding written or spoken words. So they see the stop sign, they read stop, but the word's not connecting with I need to stop the vehicle. But you should still be okay because that octagon symbol, right, represents stop. So even if the word doesn't make sense, that should still be able to cue us in to stop the car. But the person also is having issues with their visuospatial function. So they're not translating that correctly at all and blow right through the stop sign. So that's what we mean by visuospatial function. So to be a dementia, issues have to be severe enough that it interferes with a person's ability to carry out their daily activities and affect at least 2 of those 4 core mental abilities. And then let me just ask real quick, are we good or any questions with that?
We're okay for now. Oh, wait a
Perfect.
minute. Something just came in. Okay.
Surprise.
Does COVID exacerbate dementia symptoms, cause deterioration to speed up?
Very good question. And I'm not a nurse or a doctor. And again, we don't have a lot of long-term research. I can tell you a realistic thing that we saw during the pandemic with COVID is that if somebody already had Alzheimer's or related dementia disorder, the lack of activity, because it was hard to do that at home with no help, and also the lack of socialization most likely progressed people a little quicker, because one of the things we know from long-term research is keeping people physically, emotionally, socially, and cognitively engaged helps maintain them longer. So COVID definitely had a profound effect on people already living with the disease in terms of kind of moving them forward a bit, because for 2 years, for the most part, they weren't able to have those things. Any other questions with that?
One more. I used to be one more. Sorry, I used
Sure.
to be the registrar and had a cause of death failure to thrive. Could that be a euphemism for Alzheimer's?
That's a very good question. It can be, and a lot of times actually failure to thrive when someone didn't have a diagnosis of a disease, but only had a diagnosis of dementia, was used to allow people to utilize a hospice benefit. But failure to thrive could be, but it also could be depression. It could be all kinds of things. And I'm going to talk about why diagnosis is so important. Because depression can cause a lot of those things too, including failure to thrive. But depression, while not easy, is something that we can manage. So great question. So the causes of dementia fall into 2 categories. The first is neurodegenerative diseases like Alzheimer's disease. Alzheimer's, vascular dementia, which is typically caused by mini strokes or TIAs, Lewy body dementia, which looks like a combination of Alzheimer's with progressive loss in memory and ability, and Parkinson's at the same time. Frontotemporal dementias, which are the least common, that typically affect younger people, average age of onset is between 40 and 60, and mixed dementias, where the most common being a person having Alzheimer's disease and vascular dementia simultaneously. So those are the more to the least frontotemporal common diseases. And basically they are progressive, they are degenerative, and they are fatal. But there are also other conditions that can cause the symptoms of dementia. And typically they're physical in nature. These other conditions are usually marked by a sudden change in mood, memory, personality, or behavior. Sudden change, with the exception of frontotemporal dementias, isn't typical of how these diseases move. Typically, they're very slow and progressive. So sudden change often indicates that maybe there's something physical. Some of the more common physical reasons for the symptoms of dementia include depression, medication interactions, kidney, thyroid, or liver problems that aren't being managed by medication, blood clots or tumors on the brain. Anything that puts pressure on the brain changes how it works. So if we're able to relieve the pressure, then ideally, if that's the sole cause, then that person can regain functioning. Also, malnutrition, dehydration, and urinary tract infections can all cause the symptoms of dementia. So these can work independently, or often we'll see them through the journey of someone suffering from Alzheimer's or related dementia. The reality is, often people have multiple causes of the symptoms, which is why diagnosis is so very important, because we need to know what we're dealing with. If the person does have a disease, but also has some of these other conditions, they can magnify the confusion and behaviors. So managing the other conditions can help kind of eliminate some of that confusion and behaviors. And diagnostic workup. Most people kind of are of the philosophy that you can't really accurately diagnose Alzheimer's or related dementias. Or is there even a comprehensive workup for it? First, let me say that diagnosis is not just the mini mental status exam where they ask the questions and have you do specific tasks that we get typically from age 65 forward. In 2011, it became a regulation that doctors perform kind of a memory evaluation on everyone 65 and older at the annual physical, but a lot of doctors still don't do that. But basically, a diagnostic workup is comprehensive. It is multiple disciplines, and it's a series of evaluations, medical history, cognitive history, blood work, scans, usually MRI, PET scan, sometimes a CAT scan, psychiatric evaluations, looking at the person's medical history, what in their background could also cause issues with memory. Also, what in the person's family history, did anyone have a disease like Alzheimer's or related dementia? So basically, they look at who was the person, who are they now, what's different. And by doing all these evaluations, they effectively can rule out the physical causes of the symptoms of dementia, and much more specifically hone in, if it is a disease, which one it may be. So currently, they can be about 90 to 95% accurate at diagnosing the cause of the symptoms of dementia. It's through a series of evaluations and a rule out process. And ideally, what's most advocated is going to a comprehensive geriatric assessment center, which you can get the information from your local hospital, from your physician. You can ask for that. Even connecting with the Alzheimer's Association can give you a list of assessment centers in the state. So any questions so far?
None at this time.
Awesome. So let's call this what it is. I have found that just a subtle change in words and how we talk about the disease helps us as families just understand it a little differently. One of the biggest challenges with Alzheimer's disease in particular is it tends to spare physical health until the late stages. So for such a long time, the person still looks like themselves and at times sounds very much in control and like themselves. What we don't see, however, is that these neurodegenerative diseases are basically causing progressive brain damage. When you hear Alzheimer's, when you hear dementia, we typically think forgetful, but she knows what she's doing. But when we hear the term brain damage, we start to think a little differently. When someone has brain damage, they can't process the environment in the same way. When someone has brain damage, they can be very sensitive to our body language and the environment around them and react to it sometimes in negative ways. And that's what this is. These images that you see, the top left picture on the left side is end stage Alzheimer's. The right side is a healthy brain. Same on the top right. The left side is a healthy brain. The right side is end stage Alzheimer's. And then you can see here in a scan, the destruction, the damage that the disease is causing to the brain, the shrinkage and atrophy. So I think sometimes just that word switch helps us understand better the part we can't see, because the person does look like themselves for so long in the disease process. Now, there's a few different ways that you hear how Alzheimer's progresses. There's a very detailed stage 1 through 7 progression. There is the more common three-stage progression that we've actually just added two more stages to since we've learned more in the last, I want to say 5 to 6 years, believe it or not. We've had some great new research come out to give us much more insight into this disease. But the stage 1 through 7, frankly, I tell people, don't look at it. Um, there's always a tendency to ask how long will someone be in a particular stage. And as I said right at the beginning, you can't timestamp it, and you can't put someone into such a specific stage. If you look at the detailed stage 1 through 7 description, the reality is someone may wake up in stage 4, but by the end of the day, they're stage 6, because characteristics can float from one stage to another. Every day is different. Every person is different, which is why we more commonly say early, moderate, and late stage. And basically, to determine what stage a person may be in the disease process, they look at someone's overall functioning. So it's not so much what can't the person do, it's basically what parts of things they always did can they still do. It's focusing on strengths, not weaknesses. So if someone needs help dressing, I'm not going to say, that that person's definitely moderate stage then, because I want to know what kind of assistance the person needs in dressing. Maybe the person dresses themselves fine, but they're putting on 15 layers. The first thing we think in terms of that and ability is that obviously the person can dress themselves, right? So then I look at the environment. What in the environment is making the person fail at this? Maybe it's that there's too many clothes to choose from. So maybe it's thinning out the selection. Maybe the person just needs help with choosing the particular outfit, and then they can take it and go and dress perfectly. So that's kind of what they look at in every area of care, if that makes sense, and how to determine where someone may be in the disease progression. So changes that you may see as a person progresses through the disease. Judgment can be affected in folks, judgment about all kinds of things, from dressing appropriately for the weather, judgment about safety. And oftentimes we'll see folks very prone to scams, financial scams, being taken advantage of. But judgment absolutely can be affected. And again, this is progressive brain damage. So the person may have known better before, but now the disease is destroying their ability to kind of think through. It's also important to note that there are some people who never had good judgment. So for that person, you're not going to see a change, right? That's why I say it's imperative to know the person, because it's going to affect people as individual as they are. Orientation to time and place will absolutely change. When someone loses their ability to learn and retain new information, that's where you get repetitive questions, repetitive behaviors. That's where you can have someone accusing you of not telling them something and you did, because it can no longer go from short-term to long-term memory. So if a person says something like it's the first time they're asking you, and it's like the 90th, it is the first time they're asking you, because they cannot take it and put it into long-term memory. Behavior changes. I want to emphasize here that not all behavior is negative, and there is no typical Alzheimer's behavior. I always try to caution not to use they. I hear they get violent. I hear they can just go off out of nowhere. The reality is, oftentimes, behaviors are an appropriate response to things that are going on in the environment and how this broken brain is now processing that information. The best example I can think of as we're entering the holiday season is if you've ever gone to any mall at Christmas, no matter what your religion or practices are, malls at Christmas are chaotic and hectic. It should be fun. There's music. It should be a happy time, but often it's not. And sometimes in our heads, we think if one more person hits me with a freaking bag, I'm going to take them out back. But we don't do that, because our brain is functioning and we can keep ourselves in control when the environment around us becomes chaotic. But for a person with Alzheimer's, especially as that brain damage progresses, it gets harder and harder to filter out that background noise and activity. So the person loses the ability to control him or herself in the environment. So for the person with Alzheimer's disease, when the environment becomes overwhelming or uncomfortable, a person will either act on it or they'll just shut down. So the big difference there, and the thing to hang on to in terms of behavior, is that behaviors are often appropriate reactions to what's going on. So we need to become very aware of the environment and our body language, because these individuals develop an exceptionally keen awareness of environment and body language and can read you faster than you open your mouth to talk. But also that behavior becomes our most accurate communication. As words fade, as that receptive language is impaired, behavior takes on new meaning. Behavior is going to show us everything we need to know. Physical ability changes, and this is where it's sometimes difficult to understand that this is a fatal disease. But as disease progresses into the later stage, that's where we really see the physical changes. Your brain controls every function of your body. So as the brain damage progresses, the part of your brain that helps you walk and stand becomes damaged. People can lose the ability to walk. People can become more susceptible to things like pneumonia, heart failure. Your brain controls your heart. Choking, aspiration, because the mechanism in your throat that opens and closes between eating and drinking and breathing is now not getting the right messages. So that's where you really see the physical changes. And also people just losing the ability to know how to manipulate things that they never had a problem with before. And then finally, senses: sight, sound, taste, touch, and smell. Now, senses decline with age anyway. However, when somebody has Alzheimer's disease, again, more in the later stages, you may see people not getting the right connections and putting their hands in scalding hot water and not perceiving that they're getting burnt, or someone drinking down a hot cup of coffee without realizing that it's burning the esophagus or the mouth. So our ability, and that also is that safety awareness, right? Our ability to sense those things is also affected, especially in the late stages of the disease. Any questions so far?
None right now.
Perfect. All right, so let's move on. As I said, they've actually added 2 new stages to the progression of Alzheimer's disease. So still most commonly, when someone is diagnosed with the disease, when we see the symptoms, early, moderate, and late stage. But now we've determined and identified what they call preclinical Alzheimer's disease. So Alzheimer's can begin before any symptoms are ever apparent, years to decades before we ever see a thing. This is a huge focus of research, because if we can identify any of the characteristics of the person way before any symptoms show, then we can target ways to stop it before it ever gets into irreversible brain damage. So this is a huge finding. While you won't see any changes, new imaging can now identify the amyloid beta deposits. So the hallmarks of Alzheimer's disease are amyloid plaques and tangles in the brain. And basically what happens as a result of these plaques and tangles is the neurons, the neurotransmitters, the messengers are dying. So as the messengers die, less and less messages reach connection. So a visual example is if you put your hand on a hot stove, the message goes to your brain, stove's hot, your brain says, take your hand off, you react. As these messengers are dying, a person in later moderate stage or late stage may put their hand on the hot stove and the message starts right, stove's hot, but never connects where it needs to go. So the person doesn't remove their hand. So in this preclinical Alzheimer's disease, we don't see anything. Nobody has an idea anything's even happening. Genetic tests can also tell if someone may be at higher risk, especially with what they call young onset Alzheimer's disease. And young onset is classified by anyone 65 or younger. And currently, there are 2 types of Alzheimer's. There's one that affects people in their 30s, 40s, 50s, exceptionally rare, less than 10% of all diagnosed dementias. And then there's one that affects people in their 50s and 60s, also considered young onset, less than 10% of all diagnosed dementias. The more common is called late onset, which is where people from 65, 1 in 8 people can develop it. From 85, 1 in 2. So the older person gets, the greater the risk. But also, the older the person is at onset, the slower the progression tends to be. The second stage is called mild cognitive impairment due to Alzheimer's disease, or MCI. Now, MCI is a term we've been hearing for quite some time, but now they're saying there is a particular mild cognitive impairment that is associated with that very, very early preclinical Alzheimer's disease. Mild cognitive impairment is where you begin to see some of these changes. So an example would be mild changes in memory and thinking ability, but not severe enough to interfere with activities of daily living. So technically, MCI is not considered a dementia, right? We said dementia has to affect at least 2 of the 4 core mental abilities and affect the person's ability, memory issues severe enough that they can't carry out their daily activities. With mild cognitive impairment, people have memory issues that typically may be apparent to friends or family, and may even show up on cognitive tests, but they're not severe enough that they interfere with the person's ability to carry out daily activities. Also, mild cognitive impairment tends to affect just 1 of the 4 core areas as opposed to at least 2. And I see there's a question.
Yes. Is there a possibility for someone in their 20s to develop Alzheimer's?
That is a very, very good question. Now, the youngest person on record that I am aware of was 27. That's exceptionally rare. More commonly, and this tends to be strongly hereditary in families, and they've identified a specific gene called PSN1 that people can develop it in their 30s, 40s, and 50s. There's also, though, a children's disease, and I don't know if you've heard of this. They've nicknamed it children's Alzheimer's, but it's called Sanfilippo syndrome, which is similar to Alzheimer's in that a child will develop to a certain point, and then this syndrome, this disease, will start to regress them and destroy the brain, much like Alzheimer's does. But the youngest person in my knowledge was 27, but that is typically it's 30s, 40s, 50s that you may see this strongly hereditary.
Okay, and then going back to you said that there could be a hereditary factor. The next question is, my mom passed away from Alzheimer's disease. Is there genetic testing available to me?
That is a very good question. The answer is yes. There is genetic testing, and I'm going to let you be on the edge of your seat for just a couple minutes because I am going to address some of the testing, but I will say quickly, typically one of the things they're going to look at when they recommend genetic testing is how old was the person at onset. So 65 and younger is that young onset, and there are 2 specific genes, presenilin 1 or presenilin 2, PSN 1 or 2, that if a person has one of those 2 genes, that it is deterministic that they will develop young onset Alzheimer's. So again, 65 or younger. For late onset Alzheimer's, the most common genetic testing that we still see is where they look at something called ApoE4. And if you have ApoE4 from one or both sides of your family, there is a greater risk of developing Alzheimer's later in life, late onset, but it is not deterministic. So it's honestly not always recommended that somebody get that testing, because it's kind of the same what if we live on the older we get, because age is the greatest risk factor. But there are some new research studies that I'll talk about in a few moments that have identified other genes that may be at play as well.
Just one other thing here.
Sure.
Are the symptoms similar to MS?
That's a very good question. Not so much in the early and moderate stages, no, because MS tends to have more physical signs and effects. There can be slowness in speech, there can be rigidity of limbs, almost kind of Parkinsonian effects, if you will. Alzheimer's typically doesn't present with physical changes until the later stages. But someone can have MS and Alzheimer's simultaneously. They're not connected necessarily. But typically, no, you're not going to see those same kind of characteristics as you'd see with MS, with Alzheimer's in particular.
And we're all caught up for now.
All right, awesome. So not everyone with MCI has Alzheimer's disease. So again, this term has been out there for quite some time, and we're now starting to hone in a little more to see if it's due to Alzheimer's or it's mild cognitive impairment. Statistically, about 40% of people diagnosed with MCI develop Alzheimer's within 1 to 3 years, but that also means 60% don't. So it is a huge still area of focus, and now the Alzheimer's related one has really been linked as that kind of second stage where we start to see symptoms. And it's kind of a retroactive determination, if you will, because we have to see if the person, once they're diagnosed with MCI, are they going to develop Alzheimer's or not? The same process used to determine preclinical Alzheimer's can be used to determine MCI is due to Alzheimer's disease. So again, that's looking at some of the genetic factors and looking at that comprehensive geriatric assessment, the series of evaluations. And I see we have one more question before we go on to the next.
Yes. Is there a difference between Alzheimer's and dementia? I hear them used interchangeably most times.
Very good question. And yes, we talked about that a little at the beginning of this, where dementia is not the disease. Dementia is the category of symptoms. So that's important to note, because dementia, when you hear that term, you want to know what's causing the symptoms. There are two types of causes: neurodegenerative diseases like Alzheimer's. So Alzheimer's is a type of dementia, but there's also other conditions that can cause the symptoms of dementia, which include things like depression. Depression is not fatal. Depression can be managed, not easily, but can be managed with proper diagnosis and treatment. So dementia is an important term. Alzheimer's is a progressive degenerative brain disease. But dementia, those symptoms, and that's why I always kind of pair those together, the symptoms of dementia can be caused by physical things too. All right, did that answer?
Yes, and actually, you just had another question pop in.
Okay.
As a healthy individual, what should I do on a daily basis to avoid or delay this disease from happening? For example, is there some sort of better nutrition or more exercise, enough sleep, group activities, or none of these?
I am going to leave you on the edge of your seat too, because I'm going to talk about that as well. Thank you so much for that question. These are great questions, and important, because there is, for the first time in the over 100-year history of Alzheimer's disease, reasons to hope. So let me move forward a little bit through the stages here. So now, once there's a diagnosis of Alzheimer's, as I said, the most common description of progression that we use is early, moderate, and late stage. So in early stage, what we may see in the person, obviously the memory loss is beginning to affect the person's ability to carry out their daily activities. It's interfering with that. Confusion about place and time, which makes sense, right? Because if the short-term memory is the first thing to be affected, basically anything you say is not going to go in there. So that's why sometimes writing notes can be helpful for people, calling to remind them, having calendars up. That can be a really effective tool in the early stages to help keep someone to time and orientation. Problems with language. Oftentimes people will start to have trouble following conversations, may begin to have trouble getting the right word out. Mood and personality changes, and I want to say this carefully. There's this notion that Alzheimer's tends to change personality. Not true. Typically, it magnifies it. If somebody was always sweet as pie, oftentimes that person's going to be sweeter. When we see reactions, behaviors, right? That's communication. If someone gets frustrated and that wasn't typically in the person's nature, that 9 times out of 10 means something in the environment triggered it. Because the person loses the ability to control themselves in the environment, we need to now keep the environment calm, because by doing that, we actually give the person back their control. If somebody seemed like a jerk and now they're sweet as pie, that sweet person was always there. But as these diseases progress, basically the brain digs deeper into long-term memory and people get ripped back and forth between past and present without warning, which is why you can talk to somebody and they're right with you. And then you come back later and they're saying, honey, you need to help me get home because my mother's sick and she doesn't know where I am. And this person's in their 90s. That's why you see that. But that's also important to note that throughout progression, there are many moments of awareness. This doesn't mean that someone suddenly remembers everything. It means that there are moments where the person is right here and now. even in the end stages, although few and far between, there are moments of awareness. So we always want to act as though we're in it, and always treat the person with respect and dignity, but it doesn't typically change personality. If somebody was always a jerk, they're going to be a bigger jerk, but now they have an excuse because they have progressive brain damage and it's no longer in that person's control. Difficulty with executive functioning, that safety awareness, that ability to plan and follow through on a task. But typically, people in early stage can still live independently. People can often still drive fine and function as they always have, but we're starting to see these changes. In the moderate stages, this is where changes become more profound and more obvious. And while we've gotten better at earlier, more accurate diagnosis, the reality is still often people aren't diagnosed until they're just starting the moderate stages, when it becomes very apparent that there's something not right. But in the moderate stages, we start to see more difficulty with speech. People will lose or forget words, so they don't use them. So speaking and thinking become fragmented. A person may hear a word but have difficulty interpreting what that means. That's that receptive language, right? So a person may hear, come on in and have a seat, and they say thank you, and then just stand there because it's not connecting with come on in and sit down. Just to note, in this stage, we can always compensate by showing what we mean. That tends to connect longer because as the words fade, we can show. So come on in and then show the person to an empty seat. Speech may be illogical, consisting of a combination of made up words and gaps. Now, before we say, oh my gosh, that happens to all of us, by the way. So we always want to note the difference is we usually know what we're talking about and the word will come back to us in time. For somebody with Alzheimer's disease, the word isn't coming back. But think about if we've ever said, can you hand me the whatchamacallit over there? You know what you mean, but that whatchamacallit is not a word. The reason I say this is that we do know what it feels like for moments to have these diseases. That's an advantage because you can look at the person and recognize when someone is struggling with something and use what you know helps you in those moments to help them through that moment. So if the person's having trouble getting out the word, sometimes giving the word is helpful, sometimes not, you'll know. Other times it's saying, take your time, it'll come to you, to just let the person off the hook. May not be able to form full sentences, may be able to read words, but may not be able to understand. So you see that the real breakdown in the moderate stage is happening with, first of all, verbal communication and also abilities. The person's starting to lose steps to the process. So this is where someone may start to need more assistance with what we call activities of daily living, which is dressing, bathing, toileting, eating, and those things, and may speak about the past due to short-term memory loss. But remember, it's not remembering the past as much as because a person's getting ripped back and forth, they are there, which also means that people can relive good experiences and not so good experiences. And I see we have a question.
Okay, do we know why or what causes sundowning in many? Is it just as day goes on, they get more confused, tired, disoriented? I find it easier to visit or talk to my mom earlier in the day, so I tend to avoid interacting with her later in the day.
Great question. And believe it or not, don't judge me. Sundowning is my favorite behavior. Sundowning actually has nothing to do with the sun. It's what you said in your question. Sundowning is often equated to as the person becomes tired, right? For all of us, our defenses go down. If someone's up all night, they may actually sundown in the morning. So the light of day does have an effect on orientation because things look different at night, but it's not necessarily the cause of sundowning. The good thing about sundowning, believe it or not, is that it always has a start time. You can literally set your watch by it. And those of us in long-term care tend to call it the witching hour. It typically has an end time. And often sundowning is environment specific. So by knowing the start time, we know that that's too late because when you see the behavior, it didn't start here. It started subtly and built up. So when you see it, the person's already in it. If you know it starts at 3 o'clock, then we want to do what you do, visit the person earlier before they ever get into that. If you're with the person in the environment, then ideally we want to get that person engaged in something else You want to identify where it typically happens. Is it in a particular room, in front of a particular window? Is it triggered by particular events that happen? So if you look at long-term care settings, a lot of times sundowning happens at shift change. And the environment kind of is a huge trigger for it, because you got lots of people coming and going. The noise level goes up. You have people putting on props, coats, getting a purse, that all trigger someone to think, I need to get home too. So a lot of times by identifying those, we can work with it. Not everybody will sundown or does sundown. It does happen often, but those are things we can look at to try to minimize or get through that time period with less negative reactions and interactions. If someone is in a long-term care setting, I always say that sundowning is a contagious behavior. So that's why not everyone sundowns, but everybody can get caught up in it, because that is contagious. When somebody gets anxious or agitated, it kind of like a domino effect. Does that answer that question?
I'm hoping it does.
Me
Oh,
too.
wait. Oh, you know what? Here's the person said define sundown, but then also someone else said, does the person sleep more?
Okay, so sundowning is the word used to describe a behavior where a person may become more anxious, agitated, or confused. Sundowning is often equated to a person getting tired, but it's not connected to the light of day. If someone's up all night, then their sundowning time may be the morning. So sundowning is just the term that's used to describe the behavior. Typically, we'll see it in the evening. Um, the sleeping a lot, you always want to look at that. So we're in the moderate stage right now. In moderate stages, if someone is sleeping a lot and that is not normal for them, there are typically things we're going to look at as to why that might be happening. The first thing we're going to look at is the person getting enough stimulation? Because lack of stimulation and or boredom can cause the person to sleep more because they just don't know what to do. The disease also takes away a person's ability to initiate activities they always would have done. And activity is everything, by the way. It's not just leisure stuff. It's dressing, it's bathing, it's any household activity a person used to do, or incorporating aspects of what a person may have done at work. But this can also be due, sleeping, to depression. So we want to make sure that we're finding the reason for it and addressing it, because it is not typical in the early and mid stages. There's a reason for it. As we move to the end stages, sleeping is a huge part of it, because as the body is beginning to shut down, remember the brain controls every function of the body. So as this damage has progressed to end stage, if you remember those images, the person will begin to sleep more. Verbal use may be limited to 1 or 2 words or no words at all. This doesn't mean communication stops, by the way. This is important to note. 1, you can still always compensate by showing what you mean. And 2, only 10% of all any of us communicates on a daily basis is talking. The other 90 is nonverbal. It's facial expression, it's touch, it's posture, it's movement, eye contact, tone of voice. It is position, how someone is seated, how we're approaching them. All these things are nonverbal communication. And as I said at the beginning, these individuals develop a very keen awareness of environment and body language and can read us faster than we open our mouth to talk. So it is important to be aware of what you're showing, but also know that by watching the person, we can often get a sense of what's going on. Looking at the facial expression, listening to the tone of voice, even if the words don't make sense or the person's not talking, if there's no tone, obviously. But those are things you want to be aware of and look at. Relies on expressions and gestures to communicate. So again, 100% of accurate communication with this disease from moderate stage on becomes nonverbal, becomes behaviors. The person still experiences the environment through remaining senses. This is important because if you think about it, we store and retrieve information through our senses. When you smell a particular smell, let's keep to good ones, it'll unlock very specific memories. That's not lost with this disease. When you hear a familiar song, and music is perhaps one of our greatest tools, it'll take you right back to why you enjoyed that. And for people in moderate and the late stage of Alzheimer's, if you play a meaningful, familiar song to somebody's past, oftentimes that person may be able to sing, or you see the person engage in the music. Music is processed throughout the entire brain, so it pervades areas of damage. So that's a very powerful tool. And the person still absolutely understands and benefits from receiving communication. But also in the end stage, you typically see a person lose the ability to walk. You often see swallowing difficulties. From moderate to end stage, you also tend to see incontinency, where in the early, moderate, and early stages, if someone has incontinency issues, often by putting them on a bathroom schedule, taking the person every 1 or 2 hours to the bathroom, more times than not, we can help maintain continency. But in the end stages, because of that immobility, you tend not to be able to do that the same way. Also, in the end stages, as we said, people will begin to sleep more. A person may become prone to seizures because the brain's kind of short circuiting. And we see those swallowing issues. Any questions about that?
I think that was very clear, but we do have a couple more questions.
Sure.
All right, so the first one is it better to just go along with a dementia sufferer's faulty memory or to try to reground them in reality? My mother would forget that my father had passed away, and it just seemed cruel to remind her over and over again when she asked about him. So I started telling her that he was on a trip and would be back soon. Was that wrong?
First, let me say there is no right or wrong. The only person that can tell you if something's not going quite the way you want it to is the person you're connecting with. So know that. Never beat yourself up. Ideally, what we do teach is that with Alzheimer's, you can't teach. It's brain damage. And that's why I use that term, right? So for somebody with progressive brain damage, our goal no longer becomes to teach them or explain or ground them, because that's for our reality. And these folks aren't in it. They're getting ripped back and forth between past and present without warning. And the question about your father, not remembering that he died, that makes sense, right? Because that would have been new learning and it's not getting into long-term memory. So just that question told us that where she was in her long-term memory, he was still alive. And ideally, we ask that we do what I call therapeutic explanations, which is the truth, but not the whole truth. You need to be comfortable with what you're saying, because many times there's a subtle cue when we're not comfortable with what we're saying, and the person with Alzheimer's picks up on it. So if that helped your mom in that moment and calmed it, it was absolutely the right thing to do. If it hadn't have, it wasn't wrong still, it just meant let's try another approach. So never wrong. But that's, it's not about pulling the person into our reality anymore, because they're not in there. It's brain damage. So whatever the person says is where we begin. It doesn't matter what we know.
Just one comment here, and then from somebody, they just said, for what it's worth, my own experience is I learned not to argue with mom. It only served to agitate her. So
Right. And don't take yourself out of that loop, by the way, either. It's frustrating for us when we're trying to argue with someone who's not getting it. I know I'm married to an Irish Sicilian, and I just watch him fight with himself. So very wise words. Thank you for sharing that. And it's true, right? But don't ever take yourself out of that scenario. It's hard for us too.
Two more questions, and then I think you can, two more questions, and then we can move forward.
Certainly.
What type of signs will I see when the final stage appears?
So in the end stages, again, you tend to see someone sleeping more and more deeply. You may see someone not wanting, is not the right word, not able or not requiring to eat as much or drink as much. Hospice can be a phenomenal resource, by the way, and don't get stuck on 6 months or less. Hospice is not a timestamp. As long as someone is progressing, then they may be qualified for hospice, and people can re-qualify every 6 months. My grandmother was on it for 1.5 years with her vascular dementia. But those are signs, really, the sleeping more, and the not eating and drinking as much and having less output, going to the bathroom, are the biggest signs that someone is near the end. But late stages, less mobility, um, less less engaging in the ways that we were more successful in moderate stages.
Okay, and then how does Lewy body disorder relate to Alzheimer's?
Okay, so Lewy body dementia is its own neurodegenerative disease. That's a good question. And the way I kind of describe Lewy body dementia is abnormal protein deposits in the brain. Lewy bodies, named for Dr. Lewy, Lewy, are also found present in the brains of people with Parkinson's disease. But Lewy body dementia, typically right at the beginning of the disease, you get that short-term memory loss and then progressive memory loss and loss in ability. But at the same time, with Lewy body dementia, right at the beginning of the disease, you also see these Parkinson effects. So people can have rigidity of limbs where they have stiff movements. Often the person is at great risk for fall early in the disease process. People can have tremors. 50% of people with Lewy body dementia also have a sleep disorder. Typically, when you go into REM or dreaming sleep, your body's blocked from movement. If you've ever awoken in a fall dream with a that's your body unlocking. 50% of people with Lewy body dementia actually lack the blocker. So when they go into deep REM sleep, they can become physically active. So with a Lewy body dementia, you also tend to see a lot of daytime drowsiness, people nodding off and falling asleep because their body and brain is never getting a break. Whereas with Alzheimer's disease, separate, you tend to get people, they can get day-night confusion, but it typically will happen more in the moderate stages. And it could be that just confusion about what time of day it is and lack of structure, or it could be that someone is back in their long-term memory and they worked a night shift. So they're now kind of reliving that obligation, but they're two separate diseases. And the biggest difference, short-term memory loss, progressive loss in memory and ability, like Alzheimer's disease, but you've got those Parkinson effects right at the beginning as well.
And then does Lewy body always have associated dementia? Is it always?
Very good question. Yes, Lewy body dementia is always going to be a progressive degenerative brain disease. However, if somebody has Parkinson's disease, which also has Lewy bodies present, there is a dementia associated with Parkinson's, but people with Parkinson's, not everybody will develop the dementia. And if a person does develop that dementia associated with Parkinson's disease, typically it doesn't manifest until advanced Parkinson's. Does that answer?
Sorry, I started speaking and I realized I was on mute. Sorry about that.
No problem.
Can severe depressive state be misdiagnosed as Alzheimer's?
Yes, yes. And the key is we need to become active, educated advocates for our own healthcare and for those that we care for. In the not so distant past, depression was often misdiagnosed as Alzheimer's disease. So we want to make sure that we are seeking that comprehensive geriatric assessment, that they're really ruling out other things. And typically diagnosis starts with the primary care physician, but it's not often our primary care physician's area of expertise. So if there's any concerns, that's where you want to find out where you can get this comprehensive geriatric assessment. For people on Medicare 65 and over, often you always want to check first, but often Medicare pays up to 80% of the cost.
Here's a good question. How can you support the caregiver in this particular case? It's her mother when you aren't physically in the same place.
It's interesting. During the pandemic, I actually did a program that I titled The Incidental Caregiver, where you are so worried about the primary caregiver, you're actually feeling a lot of the same stressors the person does. Ways to support can be, and everyone has to be on board with it, but talking to other neighbors, family, or friends who are in the area who can help come and visit and spot, looking at options for respite care. Maybe it's a companion who can come in 3 times a week for 3 hours so she can get out to the grocery store and to the hairdresser or whatever, anything to give herself a break. And there's also a geriatric care manager which is a person who can act as you when you can't be there to help coordinate medical appointments and transportation, and help set up getting folks in the home if that's what's needed, or next step if that's what's a consideration, like placement into assisted living or skilled nursing. So there's different resources, also connecting with the local Alzheimer's Association. There are support groups, and since the pandemic, there are a lot of support groups, and also through hospital systems that are available even virtually if the person can't get out of the house. But the caregiver is the most important person in the caregiver scenario, because they can't take care of themselves. They can't oversee care of the person. And 60% of caregivers across the board, not just with dementia, get sick or die before the person they're caring for because they neglect their own well-being. So great question.
There's a few more questions here. I don't know if you want to continue or you want to.
Let me jump to the hope part and the research. We kind of covered the research, so if it's okay with you guys, I'll move past that. You know, the key is early, accurate diagnosis. Now we've identified those two new stages: preclinical Alzheimer's and MCI due to Alzheimer's. Promising paths for diagnosis. There was a recent study that identified 37 different genes that may be connected to Alzheimer's and related dementias. That's huge, because identifying biomarkers ideally allows us to target testing and clinical trials way earlier in the disease process, before symptoms ever present themselves, before the damage is irreparable. And then, as I said, there is reason to hope. One thing they've identified is there's a clear brain-heart connection. So other risk factors for Alzheimer's: age is number one, family history plays a part, but history of heart disease, history of stroke, high blood pressure, high cholesterol, type 2 diabetes, and obesity all can incrementally increase the risk of developing Alzheimer's later in life. Usually that's where I watch people ticking off, got it, working on it, calling the doctor tomorrow. This is the first time in the history of this disease, which was first identified in 1906, that we actually have something tangible that we may be able to do as possible prevention. I'm using my words carefully. Right now, we don't have a direct prevention. However, maintaining our numbers, sugar, cholesterol, weight, blood pressure, reduces the risk of heart disease and reduces the risk of stroke. And it makes sense to think that this may in turn reduce our risk of developing Alzheimer's later in life. And also, 10 ways to love your brain. I said earlier that we know for people with the disease, keeping them cognitively, physically, and socially active and engaged helps maintain them longer. Those same things also help promote healthy brain aging, right? So again, possible things that we can do now to slow down or maybe even not get. We can't say for sure, because we can't say 100% what causes the disease, but this is hope. So break a sweat, physical exercise, that helps your cholesterol, your blood pressure, your sugars, reducing your risk of heart disease, reducing your risk of stroke, and in turn, possibly reducing your risk of getting Alzheimer's. Hitting the books, cognitive stimulation, and it's not a particular thing. It's doing things that make you think differently, but you need to be into it. So if you told me work out complex math problems, I'd say forget it, because I'm not good at math and I'll get frustrated. But if you give me something that I enjoy and I'll engage myself in, that creates new connections in your brain, and increases what we call the cognitive reserve, the amount of information in there, so that if, God forbid, there is a disease later in life, we've got enough information in there that it's going to slow the presentation of symptoms. But out, if you smoke, stop it. Just in terms of the health benefits, again, reducing the risk of stroke, reducing the risk of heart disease, lung cancer, all kinds of research on that. Follow your heart. Someone asked about, are there dietary recommendations? Yeah, actually, I always recommend look to the Heart Association, right? Because promoting good heart health, that's your engine. And if your engine isn't firing on all cylinders, then this doesn't get what it needs. So the Heart Association, all the diets we hear about that are heart healthy, those are things we want to look to follow. Heads up. We know that through the current research and information about concussions, that head injuries, traumatic head injuries, also increase the risk of developing Alzheimer's later in life. So protect your head. Fuel up right. So that's the dietary, right? heart healthy diets, catch some Z's. We're hearing more and more information about the impact of sleep deprivation. So try to get enough sleep. Take care of your mental health. Buddy up, socialize. Being with other people is imperative for both the person with the disease and for us. And stump yourself. Do things that make you think differently. And now we'll get to all. And I apologize we've gone over, but I'm happy to be here as long as you need to answer the questions.
Okay, there's a few more questions.
Sure.
What type of medication is being prescribed for dementia?
So again, ideally, there's no preventative medication. Currently, the drugs that we see prescribed for Alzheimer's and related dementia, the most common are Aricept, Exelon, or Razidine. And those are called acetylcholinesterase inhibitors. And basically what that means is acetylcholinesterase is a messenger in the brain that's being destroyed by Alzheimer's. So these drugs ideally inhibit or hold back those enzymes that are destroying the acetylcholine, the messengers, and kind of turbocharging the ones that still work so that messages reach completion. They do not stop, they do not improve, they do not slow down progression. Ideally, they slow the presentation of symptoms. So they slow what you see, but it's not stopping anything else from happening. Memantine or Namenda is a drug that's most commonly or clinically was approved to be prescribed in the moderate to late stages and was meant to be given in conjunction with Aricept, Exelon, or Razidine. And memantine is meant to help allay some of the behaviors that we tend to see in moderate stages. Basically, what it does is if you think, well, you guys might remember before TVs were on 24 hours a day, they used to go static at night when it would go off air. So Alzheimer's is like static in the brain that's so pervasive you can't focus. And if you can't focus, you get frustrated and you can't function. So what Namenda tries to do is quiet the static. So it enables you to better utilize the remaining skills that you have. So again, it's not stopping progression or slowing. And I never say it right, and forgive me, I should be better at this, but the newest drug, Acuneb, I'll get that information to you, forgive me, is the first of a new generation that's actually targeting the disease. So it was just approved in 2021. We don't have a ton of long-term general use data of it, but it is exciting in that it's the first drug targeted to affect the trajectory of the disease, to ideally slow down the progression of it. COVID, believe it or not, with the mRNA drugs, that's the Moderna, the Pfizer drugs, that opened up a whole new area of research in terms of possible preventative medication and treatments for Alzheimer's and related dementias, as well as a bunch of other diseases out there. But there's a lot on the horizon in terms of that. But currently, there's really only the 5 drugs. Ideally, what we also know, though, is that by continually adapting the environment to meet the person's needs wherever he or she is, keeping the person cognitively, socially, and physically engaged helps maintain the person longer. And 9 times out of 10, behaviors are something in the environment. So by adapting the environment, often we can find ways to minimize the more negative behaviors.
I'm going to butcher the way this is pronounced. Rivastigmine also used?
Yeah, that Rivastigmine is that's one of the acetylcholinesterase inhibitors, and I think that's marketed as Namenda, but it's Aricept, Exelon. I think that's Namenda.
Okay. And does it make sense to use memory devices, or is it a waste of time? My mother generally asks what day it is every day, so I got her a large clock with the day and date, but she still will ask what day it is.
So I always say, as caregivers, we want to guide the person with the disease, but the reality is the person with the disease is our guide. So by her saying that to you kind of shows us that that's, she's not remembering to look or connecting it. So that doesn't work. Memory aids can be excellent. Try them. I always say you never know how something's going to work until you try it, but follow her lead. And the reality is, because of the short-term memory loss, she's probably still going to ask anyway.
And then does Lewy body progress faster than Alzheimer's?
That's a good question. One of the things we look at in terms of progression is the age of onset. So typically with the majority of these diseases, with the exception of frontotemporal dementias, um, the older a person is, the slower the disease tends to progress. But we also have to look at other factors like what other comorbidities or health conditions does the person have in terms of what could ramp up progression. Also, the stimulation. Are people being engaged socially, physically, cognitively to try to maintain for longer? And bottom line is everybody's different, so they progress at different rates, which is why I say you can't really put a number to it. But those are some of the factors that we look at in terms of rate of progression. Usually the younger a person is at onset, the more rapid the decline.
And are there activities that can help work out someone's brain if they are no longer doing the things that they enjoyed and challenged them because they don't like the reminder that their memory is slipping?
Great question. And part of it is how we look at it. It's not so much that people don't want to do something, but the disease is taking away that person's ability to engage in it. So what we always try to do is task breakdown. Look at the things the person always enjoyed, one thing at a time, and not even enjoyed, but just did as part of their routine. I'm going to use brushing your teeth as an example. Brushing your teeth seems like an easy long-term skill that should be intact. And sometimes we'll say, well, she doesn't want to brush her teeth anymore. It's always a fight. Think about all the steps actually involved in brushing your teeth. Typically, when we think of it, we think get the toothbrush, put the paste on, wet the brush, brush your teeth. The reality is you need to find the bathroom, you need to walk in, you need to find the light, you need to turn it on, you need to walk to the sink, identify the brush, pick up the brush, find the paste. If it's in the cupboard, open the cupboard, identify the paste, grab the paste, close the cupboard, put down the brush, unscrew the cap, put the cap down, pick up the brush. If you like water, turn on the water, wet the brush, turn off the water, put on the paste, pick up the cap, put the cap on, put the paste down, and then you're ready to brush. And no two people brush alike. I apologize, I went so fast. But we don't think about all those steps when we're doing what should be a simple task. But the disease, the progressive brain damage, literally puts the person at every single step in that task. So we want to watch the person, see what parts of it they can do independently and set them up to succeed. The parts they need help with, we want to help. So maybe for me, it's setting the toothpaste and the toothbrush out by the sink and getting me in the bathroom. And then I know what to do. For the parts that I can't do, like if you say brush your teeth and I'm in the kitchen and can't find the bathroom, don't ask me to do them. Get me to where I need to be. So by using that kind of thinking, task breakdown, we can engage the person in things they always did at the level they're able to be engaged. So if that makes sense. So we want to set people up for lots of successes instead of one big fail by saying, go brush your teeth and I can't even find the bathroom. And it's less about, we want to not think that it's that a person doesn't want to do something or enjoy it. We want to think that what in the environment is making them fail and what parts of it can I still engage the person in.
There's still have quite a few questions, but I think we're just going to take like two more.
Mhm.
How would you deal with agitation or violence?
Okay, so first thing, again, remember 9 times out of 10, those responses are a person's reaction to something in the environment. So first thing you want to do is to take a mental snapshot of what's happening when that behavior happens. Look at the time of day, look at the room it's happening in. What's happening? Is there a lot of noise? Is it too hot, too cold? Look at yourself because they read us faster than we open our mouths to talk. So if we are frustrated, if we're tired, if we're being short, and never beat yourself up, that's natural. This is not easy. Um, then sometimes we're the trigger for that behavior. And the best thing you can do is first, remember, people don't typically start here. It escalates. When you see it starting to escalate, that's when you want to change the scene, if you will. So maybe it's where you say, why don't we go out for a walk? Or would you excuse me for just a moment? I have to go to the bathroom, and walk out of the room. Unless there's an imminent safety risk, that oftentimes gives the person kind of a mental reset. But to stand there, if someone's getting more and more agitated, that's just going to ramp it up and keep it going. So ideally, you want to try to identify those early signs when someone's getting agitated. Often the violence doesn't come out of nowhere and it's not typical of disease. So again, we look for those early signs of someone getting frustrated, and that's when we want to take a step back, reset the environment, if you will.
That's great. You've provided us with so much information. So my final question to you, Amy, is how can someone get in touch with you for further information or to consult with you about a loved one with Alzheimer's or dementia?
Certainly, and I'll say my email, and email is the easiest way to get me first, and then we can set up a time to talk. It's also on this handout, but my email is Amy, AMY, E as in Elizabeth, Matthews, MATTHEWS, LLC @gmail.com. And I also, I'll put that in the chat too while I'm talking here.
That's great. Thank you so much for your time today. I know we went over a little bit, but you had such great information. At this time, I'd like to remind everyone at home